Good morning. How's everyone doing today? That's it? All right. Okay. So I'm thrilled to be helping to moderate this morning. My name is Lori Swain. I'm the Executive Director of the National Cancer Registrars Association, which is a US-based membership association of cancer registrars. And I'm joined for moderating the session with Roberto Zanetti, and we're going to alternate between introducing speakers. Once we finish the main speaker, our first keynote speaker here for 30 minutes, we'd like the other speakers to please all come up front and sit here, just to speed up time and opportunity to keep the session moving. Also, we're going to hold questions to the end of the session, just to allow enough time, again, for everyone to present before we get into the Q&A session. And one final reminder about that, when this session's over, we're going to move into an award ceremony, so please remain seated and we'll continue on with that program. I am very excited to introduce our keynote speaker this morning. Dr. Alejandro Mahar Betancourt is the head of the epidemiology unit at the Medical National Center in Mexico City. He's a member of the Board of Governors, and he was a member of the International Narcotics Control Board at the United Nations. He obtained his MD of medicine at UNAM. He's a certified surgical pathologist with a master's and doctor of science degrees in epidemiology from Harvard School of Public Health. And in 2000, he was appointed the Edward LaRocque Tinker Visiting Professor at Stanford University. It is my pleasure to introduce Dr. Alejandro Mahar Betancourt.
Thank you, and welcome to this special session. It's really a pleasure and an honor to be here with all of you. I'm particularly thankful to the International Agency of Registry, International Agency of Research on Cancer, to Marion Piñeiros, and as well to the, of course, National Association of American Cancer Registries, the North American Association of Cancer Registries. So I have been here a couple of years ago presenting some of the ideas that Mexico would like to develop to set up finally a valid, high-quality, population-based cancer registry. So what I'm going to talk this morning is basically the story of what has happened in these 2 years in terms of what is the status today of our cancer registry in Mexico, which I think it's of most important and historical commitment in Mexico that finally it seems is already taking place in our country. So basically what I have in these 27 minutes that I have left, I would just want to address these 5 topics. Basically some demographics of the general status in Mexico, this cancer epidemiology of the data that we have without a population-based cancer registry, some of the explanations on why we haven't set up this cancer registry for many decades, explaining through the Mexican health system, and of course, what has been the story of this network of today, based on the population-based cancer registry, that hopefully could give us a better idea of what's going on in Mexico. I would just very briefly estimate what is the preliminary results of this network, what are the limitations that we have found, and of course, what are the next steps and what will be the future of this population-based cancer registry. This is the total Mexican population. It's the first Hispanic country in terms of the number of inhabitants. It's more than 125 million people living. This is the distribution of our age, and as you could see, we have a wide base of people younger than the 3rd and 4th decade, but little by little, yearly basis, we have since 1922, basically immediately after the Mexican Revolution, a rapid, continuous, and permanent epidemiological transition. And what I have described many years ago is that in Mexico we have a kind of a stationary epidemiological transition. where we have a highly epidemic pattern of diabetes, cancer, other chronic disease, but at the same time, in certain areas of Mexico, we still have a high level of incidence and mortality of infectious disease and perinatal mortality. However, we have, I will say, two important waves. One, consequence of the chronic disease, diabetes, obesity, overweight, cancer, and pulmonary disease, and at the same time, we haven't been unable to completely eradicate some basic infectious disease and maternal perinatal mortality, highly prevalent in some sub-areas, suburban areas, in particular in the south and in the southwest of Mexico. But today we have a very strong epidemic of diabetes, becoming rapidly the first cause of death, although cardiovascular disease is the first cause of death. And immediately after those two, the group of malignancies are the third cause of death in Mexico. So, as I mentioned, the life expectation for the Mexican population for women is around 80 years old, among men is 78 years old, and one of every 5 Mexicans now is getting to the 65 age group and older, so we have a rapid increase in the trend of older people getting into this pattern of chronic disease mortality and incidence, where we have to better understand what's going on, what are the tendencies, the need for medical care, the prevention, and that's one of the big challenges of setting up finally a population-based cancer registry in Mexico. I'm sure that all of you know this specific map generated by the International Agency of Research of Cancer, which describes, I will say surprisingly, the absence of Mexico in this context of a better quality cancer registry in comparison with other Latin Americas, where we have a similar socioeconomic level of development, and for some reason that I will try to explain in the next minutes, we haven't been able to really catch up with countries with a similar development like Colombia, Chile, Brazil, Uruguay, even some Caribbean countries like Cuba, and Mexico has been traditionally stuck in just local and regional data through hospitals and clinical series of cancer that has given us some indirect spectrum of the magnitude of cancer registry in Mexico. So I will take just some minutes of what you also know very well. It's what is the data that today exists in Mexico with indirect information from mortality gathered through the GloboCan and recently published, as you know, in the Cancer Journal of Clinicians. So, as is expected for the rest of Latin America, we have as number 1 among men, prostate cancer, colorectal, lung cancer, testicular and gastrointestinal cancers among men. And among women, as in different patterns and different incidents in other parts of the world, breast cancer by far is the more common malignancies, but it's still, as any specific country in middle-income country or developing country, closely to breast cancer, we have still cervical cancer as the number 2, together with ovary and thyroid cancers. And if we see at the incidence and mortality of this disease, it's pretty much the same. Breast cancer among women is the number 1 cause of death. Among men, of course, is quite similar, where prostate cancer is the more frequent malignancies and at the same time is the number 1. And if you see the whole spectrum of malignancies common in Mexico, you emphasize the importance of setting up a high-quality population-based cancer registry, reinforce our primary and secondary prevention efforts, because this is really the opportunity of Mexico to reduce the number of people that are dying, unfortunately, due to the fact that most of these patients, 60 to 70% of them, arrive to the hospitals in advanced stages of the disease with a high cost of treatment and the low probabilities of survival and control. So just getting some incidence data according to the GloboCan is what we see. Prostate, breast, cervical cancer, gastrointestinal cancers are the challenges for prevention, diagnosis, and treatment. And among women is pretty much the same story. I would just want to emphasize as well that for women, breast cancer, thyroid cancer, and cervical cancer are one of the big challenges that we have today and for the coming years. And if we look at the mortality, well, it's pretty much what we have said in competing in for breast and prostate cancer, and in terms of the incidence, and pretty close to that. It's other malignancies, clearly with the opportunity of early detection and prevention. And among mortality, well, unfortunately, there are prostate, breast, cervical cancer, and colorectal cancer. Our main focus and our main opportunities to really reinforce, as I mentioned, primary prevention, secondary prevention, and rapid referral to an oncological center to reduce this unacceptable high mortality, particularly for cervical cancer in Mexico, that for many decades is still the second cause of death among women between 25 and 64 years old. And in the case of pediatric cancer, as in the rest of the world, according to the GloboCan, and it's still in the clinical series and the preliminary data that we have set up in Mexico, we have, of course, leukemias, tumors of the central nervous systems, and hematological malignancies as the main causes of incidence and mortality among children with cancer. And finally, through the GloboCan, we can see clearly that the age is the more important predictor for incidence and mortality in Mexico as in the rest of the world, with some specific variants. We have seen in breast cancer a growing epidemic of breast cancer among women of 40 years and younger, and now 18 to 20% of the patients that arrive to oncological centers in Mexico, particularly at the Mexican NCI, which is a national referral center, we see 18% of them 40 years of age and younger, without any specific risk factors, 20% of them triple negative, and of course it has become a huge challenge because most of them, as usually in the older group, arrive in advanced stages of the disease. But overall, I will say, with exception with breast and cervical cancer, that as well we see women among 30 and 40 years old arriving. The age is the major risk factor for diagnosis and mortality among Mexico. So what I will try to explain in the next few minutes is what has happened. Why Mexico, being a middle-income country, what we have been unable for many decades to set up a good quality of population-based cancer registry. I can tell you that I have been working in the Mexican health system, well, since I was a medical student, many years ago. I have been practicing medical through 30 years old, and at this, almost 30 years ago. And still at this time, I do not understand the Mexican health system. So it's a big challenge to understand it, and I will try to do it in these next few minutes, because we have 7 different systems of social security. So I will not be specifically in some of the issues of that, but it's IMSS, 39% is the people that have a regular job. ISSSTE is the people that goes to the Mexican, that works as a bureaucracy, within the bureaucracy. And then we have Pemex, which is the old company, the Marine, the military, and then in 2003, and maybe you have read some of the debates today in Lancet about the creation of a 5th system, which is the Seguro Popular, which covers people outside of this social security scheme. So to put together all these systems and try to talk through them and get data from them, where we do not share patients, we do not share budget, we do not share administrative issues in terms of the access to clinical guidelines and so on. That has been one of the major reasons why it has been so difficult to all of us get together and organize a single data set of cancer registry that will give us the trends and the story of the cancer registry in Mexico. And in addition to that, we have a small group, it's really 10% of the population who has a private health insurance, but since some of the health systems have a low quality, they switch to the private. So they have social security system, and as well they do outside pocket paying, for getting medical care. So that absolutely puzzle of Mexican system to provide care has been one of the major reasons to set up this cancer registry. And just some of the descriptive data that we have in Mexico in terms of what we see within the clinical setting. This is a group of women, a cohort of breast cancer women seen at the Mexican National Cancer Institute, one of my positions there was for many years as an epidemiologist. And what we see here is basically advanced stages of the disease in this woman of more than 4,000 cases, and clearly comparison with the United States, where it's a mirror, a contour mirror, where you here in the United States and Canada, well, early stage is around 60%, and in Mexico, it's around 10%. So that's also one of the big problems in Mexico. And in addition to that, many of you maybe have visited Mexico, and it's clearly full of contrasts, where are areas of fully development, middle development, and very, very low development. And that, of course, reflects the mortality in terms of the leukemia, which is, I think, a good parameter to evaluate access and treatment, where children or kids treated at the Pediatric Institute at Mexico City, they reach survivals for leukemia over 80, 90%. But if you go to the southeast or southwest of the country, well, that opportunities of survival are around 40 to 50%. So as well, this is a huge opportunity to improve access and diagnosis all over the country. So those arguments for years have encouraged us at the Mexican NCI to really finally set up a very, hopefully well-organized, high-quality network of population-based cancer registries. And this is a brief story that without the support of the International Agency of Research on Cancer, that could not be done. We reached them. We established an agreement at the middle of 2016. Then finally, we get into the Global International Cancer Registries access information. We make several visits to different cancer registries, particularly in Colombia. Then we have a visit from Impact. And then finally, we have set up since 2017 a group of people that have established high-quality population-based cancer registries. In parallel with that, we made a lot of lobbying within the Congress and the Senate. And finally, in July of 2017, unanimously, the Congress and the Senate established the first law for the National Cancer Registry in Mexico. And that provided us some initial funding that, of course, helped us to set up what we have today. And what we have today, in support with different international agencies, the plan is to get what I call a group of sentinel population-based cancer registries, setting up a network of population-based cancer registries representative of all the country. As I mentioned, it's a huge country with more than 125 million people living there. Impossible to conceive a nationwide cancer registry. So these are our initial setups for population-based cancer registries, hopefully representative of the Mexican population. We have been working very hard through funds of the pharmaceutical industry initially, from NGOs, and now today, finally, through federal funding, around 1.5 million we got for this year, to set up a group of people that will be working in these networks. And we have developed, through the support of the International Agency of Research on Cancer, our operational manual to homogenize the quality and the system to collect the data, and this is nothing new. We basically identify the sources. We have an agreement in the different local governments. We collect the cases. We have developed a similar software of the CanRec 5, based in the CanRec 5, which we call it Red Cancer Mex, which will be based in the iCloud. We validate those cases. It's approved by the medical oncologist, which is supporting and counseling this cancer registry. And finally, we're getting some databases to getting some results. So these are some preliminary results at this time. I have to recall that we start last year, in 2018. Marion Piñeros has been very strict, following us, the quality, the numbers, the sources, the validation of the cases. So these, I will say, are the first validated cases in this network, almost 7,000 cases. We have this age distribution adjusted by gender. And of course, what we expected indirectly from the GloboCan, we have this nice distribution now that we have seen in different cities, where we, of course, focus now our efforts for primary prevention within the new government with the discussion of what is needed in terms of mastography. We still have to continue mastography, doing in Mexico with a coverage of 20% or less. We still have a high incidence of cervical cancer, which is unacceptable for a low middle income country. And of course, the opportunity for, among men, of prostate, gastrointestinal cancer, testicular cancer, since we have these 7 social security systems that supposedly will provide free medical care to the group of patients with cancer nationwide. So the challenge is to really identify one of those cases, high incidence, and get an optimal referral system where they are occurring to oncological centers. And this is as well for kids, and as I mentioned to you, here is an opportunity because according where the kid is diagnosed, the timing, the referral, and the access to pediatric oncology, and accordingly to the social security system, the drugs to treat this kid will be sufficient. Still, we have a high level of mortality of leukemia in some areas of the country. So we have set up several collaborations with the University of California, San Francisco, with a very nice network of St. Jude's through Carlos Rodriguez Galindo to support this cancer registry, see where the kids are coming, have this network with the support of the St. Jude's, really make a quick referral. We have established a national referral center for minimal residual disease diagnosis, and through the National Genomic Institute, hopefully this opportunity that we see it closely to get a better spectrum with leukemia, at least, is one of the big goals of this population-based cancer registry. So just to close to be concluding this opportunity of the plenary session, I will just mention, of course, some of the limitations that we have and that we have found in setting up this population. Traditionally, there were isolated efforts from NGOs, from private industry, and now finally we are all of us within the Mexican law of the population-based cancer registry. As I mentioned and emphasized, this multi-fragmentation has been a major limitation, but today the government, our new president, has made a strong commitment publicly every day in his daily press conference, emphasized the need to improve our Mexican health system through a universal coverage. So I think that we are running into this channel with the Mexican president that will better access to get better dialogue with the different health systems in Mexico. Of course, always, and you have extensively suffered, I am sure, like me, to get the budget, but finally, since it's a law, we believe that in annual basis, we're going to get sufficient budget, although we still have to be lobbying closely to the Congress to get adequate funding. And in Mexico, as I mentioned, it's a whole mosaic of access and infrastructure. If you go to the north part of the country, there are medical records, and there are electronic medical records and excellent systems of reference. In the middle part of the country, it's not that much, although NCI, it's based in Mexico City, which is in the middle of the country. But all the south, which was almost 40 to 50 million people, the conditions are more complicated. There are no medical records there. It's basically in paper, so we have to make a major effort there to really optimize the quality, and that's why we decide 2 or 3 cities in the southeast with an optimal oncological structure to really rely on the quality of the data that we're getting there. And with that spectrum nationwide, I think we can make the case of the need to more funding and to better interventions for that. So what is next is, of course, we are getting these agreements, improve our system to capture and getting into the cloud. And of course, one of the most that we have learned is the quality of the data to be included now in the information that the JARC publishes every 4 years. And we have defined that we need a National Cancer Council to put together all these institutions, and this council will really monitor, support, and lobby the value of the population-based cancer registry that in my personal case I have been for almost 20 years after I graduated from Harvard to really push from the need from population cancer registries in a country like Mexico. And of course, with all these elements, the natural next step will be to help to set up a national cancer control plan. And that's what I will finish. This National Cancer Control Plan, of course, as we see the spectrum of disease in Mexico, goes from primary prevention to palliative care, supporting all this population that is hugely needed. A specific point is palliative care, because really the access to morphine, it's complicated in Mexico, it's overregulated, it's a, there is some, I would say, limitations or not very, I would say, confidence from primary health physicians in how to prescribe morphine in Mexico, so those patients have to travel miles and miles to get to a second or third level hospital to get an adequate prescription for palliative care. So that's also a very important component of this National Cancer Control Plan. And of course, the dream, and sometimes I tell my kids, maybe my grandsons or my great-grandsons will finally understand the Mexican health systems, where we will work all together, because it's already set up. It was born in 1943, but if we have 7 different rooms, well, it's very complicated to pass from one room to another one. So the idea is that really within the private, the public, the government, the new health system that the current Mexican president wants to set up, hopefully we can travel once in another. As an example, I just have 1 minute to go, 1.5. We have a radiotherapy unit, let's say in Acapulco, in Seguro Social. Not in Seguro Social, in the public sector, Seguro Popular. Just across the street is the Seguro Social, another infrastructure system. Well, the patients from here, from the Seguro Social, cannot go to Acapulco Oncological Center. They have to wait to travel to Mexico City. But there is a space in Acapulco. But since there is an administrative paradigm there and puzzle, the patients have to wait to get a space in Mexico City, and they will have to travel. And of course, they travel from 200 miles. It's ridiculous. And then where they want to stay when they can just cross the street and get optimal radiotherapy. So that will be the idea of this network of collaboration with that. So then in the last minute, I just want to thank, of course, this has been really an army conducted by Dr. Palafox, here present, by Omar Montelongo, who are the coordinators of this cancer registry, and the effort of the current president and the Ministry of Health is really to focus on prevention, early detection, and treatment, of course, in overall in all the pathology in Mexico, and of course. And this is the last slide. I just want to emphasize that Mexico definitely is still part of North America. So, so I have talked here with colleagues and presidents and elected presidents that we really want to be part of this family of the North Association American of Cancer Registries. And this is the second time that I'm here, so hopefully now in yearly basis we can assist to this meeting, be part actively of the North Association of Cancer Registry through the Global International Cancer Registry, of course through the JARC, and of course that your support will be an absolutely way to change the thinking of the Mexican government that will have to be work at the North American Association of Cancer Registry, and then be part of this major effort that you have made already for many decades to a better cancer control in Mexico. Well, thank you. I just want to thank all the people that have participated here. Y muchas gracias por estar aquí. Thank you again for everyone.
The next presentation concerns the new edition of the International Classification for Oncology, and this work will be presented by Ariana Znaur. Ariana graduated in medicine at the University of Zagreb in Croatia, when she also got her PhD. Then he started working at the National Cancer Registry of Croatia, that she directed for many years, and during this period she has an intense activity, international activity, mainly in Europe. Then she joined the International Agency for Research on Cancer in Lyon, where she is in charge of the hub of Izmir in Turkey that has the coverage of this project for Middle East and North Africa. Please, Ariana, the presentation will be shared, will be alternate with Valerie White, that is a co-author of this work.
Thanks, Roberto, for a nice introduction, and I'm very happy to be at my first NAACCR meeting. I'll be talking about ICD-0 3.2, and I'll share my presentation with Dr. Valerie White from IARC Classification of Tumors group. So I will say something about the background and work that we have done in updating the classification and its implications, and then Val will say something about the blue books. I think this needs not much explanations for this audience, what the ICD-03 code is like, but maybe just to remind that the code also consists of a diagnostic term, and then a diagnostic term can actually can be preferred, synonym, or related. And in the context of novel findings, it is frequently that the terms can change. Some can be moved from preferred to the synonym, some become obsolete, and so on. So the maintaining and updating ICD-0 classification is a task of IARC, and we were asked and even requested for a while to do it. So finally, two complementary working groups were formed. One is the IARC WHO committee that had a task to update the morphology list itself, and then and of course with the members from the pathology community. And then the other working group was the NAACCR working group with the representatives of cancer registries worldwide, and the task of implementation and dissemination in the registry community. This is a timeline of our activities that have started now more than 1 year ago with the kickoff of the working groups in April. One of the important moments was also a meeting at the WHO in June last year, where we actually managed to defend the ICD-0 in terms of explaining that the new ICD-11 will not be able to replace the use of ICD-0 in cancer registries. And then what we did for the first time is to open the materials, the updated classification for public consultation. So the tables with the new morphology codes and changes were available for comments since October last year. And then we thought we will receive the comments by mid-November and update the classification by the end of the year. But then we received so much feedback and so constructive from many registry associations, including NAACCR, of course, and but also individuals, that it took us actually several months to update the classification. And then the final documents were available, have become available in April, and IACCR has distributed the information, and you can find them on the IACCR website. And now what is remaining is also to make so there will be also a book. It will not be a printed book, but a PDF. And this is now in progress, so to have also the regular structure of the book with the alphabetic index and so on. So what is available now is the 2 Excel files. I hope you have had a chance to look at them already. So this is morphology. This is the new morphology list. There were no changes in topography for this revision. And then the other document is the list of changes compared to ICDO 3.1. And this is the document in which the NAACCR working group put really a lot of effort to document all the changes. There were more than 600 changes documented, of which most were actually changes in terms, whereas there were less changes in codes, some changes of behavior, and also 50 new codes. So, of course, this will have implications for our future work in the registries, in particular in training in using the new codes or new, I think in particular of raising attention of the registrars to the codes that were previously benign and now have moved to malignant. And unlike the previous update, the changes go throughout the system, so not all of them are just for lymphoma, leukemia. And then we will need to update the check conversion programs, CANREC, and so on. All that said, this is actually a minor revision compared to the need, because what we are facing actually is that in the current format there are not enough codes. There is no possibility to add as many codes as there are new entities. So in the next iteration, it will need to be a new edition, ICD-04, which will then require probably one more digit for morphology and also some changes for topography. So this is a big task then to embark upon as the next step. And with this, I will leave to Val to bring you in the Blue Books world.
Good morning, and thank you, Ariana, for sharing this talk with me. I wanted to tell you where the ICDO codes actually are derived from, and they actually come from the World Health Organization of Classification of Tumors, and this is a classification of all known human tumors. And they are presented in a series of books known as colloquially as the Blue Books because of their blue cover. And this is the picture of the cover of the first book in the 5th series, which we are just embarking upon. And it just went to the publishers last week. This series will have 15 books. There were 12 in the previous, and in this 5th edition, the last 3 books will include material from all of the other books. Right now, we are working on the first 4. As I said, the digestive system just went to the publishers. The breast tumors are in late editing. The soft tissue and bone are in early editing, and the female genital tract is being written. So over the next 2 to 3 years, all of these books will be updated. And this should be thought of as a classification spread across 15 books, not 15 classifications. Now, the ICDO codes are up front and center in every chapter of the book, and this is an example from the first page of the tumors of the esophagus. And the codes are also displayed at the beginning of every entity that's described in the book. They're also used to inform the epidemiologic maps, which are present in the chapters that concern the most common tumors. The Bluebook Community consists of the Bluebook team, of which I'm and Ariana are members, working at IARC in Lyon, France. And the way the books are made this time has changed from the previous series in that now we have a standing member board, editorial board, and expert editors are invited for each book. We assume that most of the users of the books are pathologists and have estimated that there's approximately 60,000 pathologists in the world, but we have tried to make this upcoming edition more user-friendly for people in other areas such as cancer researchers and cancer registrars. We have attempted to include the multidimensional nature of cancer by describing every tumor under these headings, here shown in a list, which includes the ICD-0 and ICD-11 codes. And the books are used extensively for the actual diagnosis of tumors being used right at their point of origin of the diagnosis. Along with all of this information comes the challenge for classification of information overload, and in this edition we are trying to introduce systematic reviews into the process for any changes in the classification. So what's coming up in the last 10 seconds? We are going to be putting these books on a website which will be launched at the European Congress of Pathology in Nice, France in September. We plan to still have books and they will still be blue. And throughout this series, we will be collecting the codes. As each book is done, we are updating codes, and this collection of codes will then be used to inform the next iteration of the coding system, as Ariana mentioned. So I'm originally from Vancouver, and I hope you have enjoyed yourself here and enjoy the next few days before you return to your hometowns. Thank you.
Thank you very much. So our next speaker, and there, with the lighting, there might be a disco ball that comes from the ceiling at any moment, just so you're aware. Dr. Gonzalo Ferraz de la Cerda is going to share the findings of his research question, do classification rules for coding cancer site impact estimates of rates and trends? Gonzalo is a research fellow at NCI in the US. He has 12 years of experience in the areas of cancer registration and data analysis. He works heavily with IMS and people from registries all over the world to improve the SEER prep software. And he's an expert in CanReg 5, and Gonzalo has been providing guidance and training for NCI's work through the NAACCR's regional hub in the Caribbean. Gonzalo has a doctorate in veterinary medicine and a master's in human oncology. Please join me in welcoming Gonzalo.
Good morning, everyone. I thank NAACCR and NAACCR for the opportunity of presenting this in a plenary session. So, where do I change? Okay. So everyone knows here that there are two sets of classification for multiple primary tumors, two sets of rules for multiple primary tumors, the SEER rules and the IARC-IACR rules, also called international rules, and that they differ. So when you don't adjust for these multiple primary rules, you get figures like this. This concerns incidence data in the SEER 18 registries area from 2000 through 2015 for several cancer sites. So when you don't adjust for those primary rules, the international rates, the IACR, IARC rates always fall below the SEER rates. But if you adjust for those rules, and you can adjust for those rules in SEERStat, so if you use the software that software to analyze your data, you can adjust that to the international rules. When you adjust that, one other question arises, which is the the differences between the classification for grouping the cancer sites. So here also, SEER and IARC-IACR might differ. So the SEER uses the SEER site recode. So it uses the morphology and topography code to come up with this SEER site recode. And the IARC-IACR uses the same topography and morphology code to come up with the ICD-10 code. So those two codes are converted into an ICD-10 code, and then these ICD-10 codes are grouped and are presented in tables, as you well know, in the CI5 series, for example. In the CI5 series, the ICD-10 codes comes as in different groupings. So would these different site groupings also impact estimates of rates and trends and thus their interpretation? This was our question, and I think this is important for many cancer registries operating abroad the US, especially when they want to compare their data with SEER data, and especially when they have more recent data which is not yet available in CI5. So for this, we first used a SEER incidence database for 2000 through 2015, and we converted all ICD-03 morphology and topography codes into an ICD-10 code using IARC Cancer Registration Tools software. And we call this the CI5 site recode. So this site recode, we made it available in this SEER incidence database. We used case diagnosis in 2015 in the SEER 18 areas to assess level of concordance between the recodes, so the CI5 recode and the SEER site recode. And finally, we used the same database, but for the period 2000 through 2015 to assess, to compare trends between the recodes. And on this, on the left, you can see the CI5 grouping as it appears in the CI5 series publication. And on the right, the SEER site recode. These are only the labels, not the codes. You can see there are some differences in the names. And 14 out of 61 cancer sites groupings had a perfect match between the CI5 grouping and the SEER site recode. And in some of these cancer sites, we had to group the data, the groups, to regroup the groups to put them comparable, to make them comparable. And 9 out of 61 had an almost perfect match, so this means that it's almost 100% of the concordance between the two recodes. Also, we had two groups, at least these sites, to have the data comparable. And for these, the trends for these sites that presented an almost perfect match, the trends are exactly the same. So the annual percentage change were exactly the same. For example, for stomach and female breast, these were the most significant in these site groupings. Then 25 out of 61 had a minor non-concordance. So this falls between 95% and 99% of matching between the two recodes. And we had to group also these cancer sites to become comparable. These are the remaining ones. This is the largest group, and I only present here two of the most significant ones in these groups, so colon and lung. So even if the match is not perfect, so even if it's between 95% and 99%, the trends are still the same. So they overlap almost completely between the CI5 site recode and the SEER site recode. And finally, 7 out of 61 presented major mismatches. Obviously, as expected, these the two main ones fall into the hematolymphoid neoplasms categories, like non-Hodgkin lymphoma and lymphoid leukemia. And for this, you can see that the trends differ significantly. So they are not comparable at all. And you also can see in 2010 that there's a difference. So there's the rates in the CI5 recode fall a little bit, but for non-Hodgkin lymphoma and in lymphocytic leukemia, you can observe a jump in the rates also in 2010. And finally, for 6 out of 61 site groupings, no concordant site group could be matched. So there were no group in the SEER site recode to group with in the CI5 grouping. So, for example, the differences between especially in the non-Hodgkin lymphoma and in lymphocytic leukemia categories exist because SEER site recode applies different rules compared to the CI5 recode, to the international rules for grouping cancer sites. So, for example, for this specific morphology code, chronic lymphocytic leukemia, in the CI5 series, this code is converted into C91.1. It's a ICD-10 code, which falls into the lymphoid leukemia grouping in the CI5 series. But in the SEER, it is converted into lymphoid leukemia or non-Hodgkin lymphoma according to the primary cancer sites. So for lymphoid leukemia, those are the primary cancer sites, and for the non-Hodgkin lymphoma, all other primary cancer sites. And the same for extranodal marginal zone lymphoma of Maut. But here is exactly the opposite. So these are the differences. This is why the differences occur in these two cancer sites. So the majority of cancer sites are directly comparable. Non-Hodgkin lymphoma and lymphoid leukemia presented major mismatches and should not be directly compared. Changes in coding rules determined by the WHO in 2018 and implemented in the SEER program in 2010 might explain differences observed between classifications from 2010 onward, specifically for those two cancer sites. And the new CI5 site recode is already available in the latest version of SEER Prep, the software that is used to convert a cancer registry data into the SEER stat format, and will be made available in the most recent SEER incidence databases. Thank you very much.
The next presentation is from Professor Swaminathan and is concerning cancer surveillance in the Dindigul district in India. Professor Swaminathan has a PhD degree in statistics from Madras University in India and also a PhD with honors in epidemiology from the University of Tampere, Finland, under the supervision of Professor Maki Akama. He is presently an assistant director of Cancer Institute in Chennai and professor and head of epidemiology, biostatistics, and cancer registry at Cancer Registry Department. His research interests are in cancer registration, survival analysis, and modeling. He has been the editor of the 10th volume of Cancer in 5 Continents, and he is well known as the editor of the SURCAN2, the large project on a survival estimate in low-middle income countries. Please, Professor Swaminathan.
Thank you, Chairman, for the kind words, and I thank Freddie Brave for this opportunity. To introduce the Dindigul Amblikay Cancer Registry, Amblikay is the remote village in the state of Tamil Nadu that's in South India, and it is about 425 kilometers from Chennai. That's the capital city of Tamil Nadu. It covers a large rural area and caters to about 2 million population with a slight male preponderance, and that has now changed over time. Cancer registration is done by active method. That's the key there. We get about 2,000 notifications, of which 1,600 and odd qualify for the final analysis. So the objectives for starting this registry was there were no rural registries in Tamil Nadu at the time, and we lacked data from rural parts of the. And secondly, there was a cluster randomized cervical field intervention trial that was organized there by IARC. So this registry took the opportunity to evaluate that program. So registration method is by active method. The catchment area is widespread, because there was not even a pathology lab when we started the registry there. Of course, it had an NGO that offered radiation therapy. Other than that, people had to seek treatment outside the district most of the times. So case finding was essentially by medical record. We went by that because we had a very good health record association in the state. And apart from that, we did house visit for almost all the cases for completeness of details, and that is the strength of this registry. So just to take you, how we operate, the green one is the local district, which had about 81 sources, but the yellow ones are the ones where people go for treatment, surrounding districts, and the red ones are the distant ones, and of course the purple is where the Chennai city is. So people traverse about 200 to 400 kilometers for getting cancer treatment. So this is how we work. After collecting the basic information from the records and determining the cancer case was from the registry, what we do is the house visit. And that's very important to get the details completed on patient ID, which is very essential to eliminate duplicates. And of course, we do the form completion and then analyze and publish results. We report data both to the government of Tamil Nadu, government of India, and the WHO. So coming to statistics, the incidence statistics, for the first 3 years of operation and the latest 3 years that we have now. Rates clearly showed an improvement, but we felt it was still lesser than from the urban areas. But then it was still more than what Bashi reported. The important thing is, usually in India, if you see, the ASRs will be more than the CAR because of the young population in urban areas. But then here, the demographic transition was already there, and then we had lesser ASRs then. But anyway, you had an annual increase of about 1.5%. There was a female preponderance, of course. Just this is too premature to do a trend analysis, but then it clearly gave a changing cancer pattern. The first 3 years in the latest that we have, stomach still was the major cancer among men. And that was a surprise. Lung is emerging, rising among men and women. Large bowel is now within the top 5 and 10 in men and women. And the emergence of oropharyngeal cancer is of concern because this is the area where the HPV prevalence among women was about 12 to 14%. But of course, we have to launch some epidemiological investigations on that. But the positive things were cervix, mouth cancers, and esophageal were coming down among women. Mouth cancers are not coming down among men. So this is something for the tobacco cessation activists. This is one thing which I am proud of, because this is the only registry in India that could give variable cancer incidence by education group. If you take education status as a surrogate for socioeconomic status, you clearly see there is a direct relationship for the incidence of breast cancer. As the literacy levels increased, the incidence of breast cancer increased. There was a 6-fold risk of breast cancer among those women who had at least 12 years of education. And this translated even in the age-specific incidence curve. If you see, we have a very good. And if you look for the cervix cancer, it's just the reverse. There's an inverse trend. So this clearly identified the high-risk groups for any intervention activity by the government. We were also, since we did the house visit as a routine, we do have very good data on survival. The average survival for all cancers together in this district is about 30%, 5-year survival. Highest, of course, for breast and the least for the lung, the top 10 cancers that we have. What is very impressive is the 5-year complete follow-up of about 89%. And you must understand that more than 2/3 of them were got only by active follow-up. Of course, this survival is the least among those in India. And then we wanted to have, we knew that we were missing cases. So we wanted to have an objective index of what we are missing. So what we did is we embarked upon a population survey by stratified random sampling. So about 19,000 households covering about 100,000 individuals from 41 villages. They were carefully chosen, of course at random, but then representing border areas as well as distant places from the registry. So when the survey data was linked to the registry database, what we found out is out of the 166 cancers that were identified, 55 were just identified only from the survey. So we thought we are missing about 1/3 of cancer cases. The primary reasons were we were not covering enough sources to get the data. They were all located especially outside the district, making it very difficult to enumerate cases from there. So the government took a decision that statewide cancer surveillance must be launched. So we launched this state cancer registry, which covered about 78 million population. So here, naturally, there was an increase in the number of sources. So this came to our aid so that we were able to cover more sources that improved the coverage of this particular registry. Now, the cancer registration is by mixed case finding, though majority are still by active method. Cancer is now a notifiable disease in our state under Public Health Act. So we do get notifications to the registry. Finally, this is one registry that was used to evaluate a well-organized screening program. So of the 40,000 women in intervention and 31,000 in the control group, these are published results. Very clearly, this registry framework was used to evaluate the program in an unbiased manner. So in that, we clearly demonstrated an advantage in the screened group. This screening was by visual inspection with acetic acid. So in summary, the registry has provided the first set of cancer incidence statistics from rural part of our state, but the rates were almost half of what is seen in Chennai, because, for example, lung cancer rates are half of that in Chennai, though the smoking rates were the same in both these areas. So these are some of the things that brought to the fore the contribution of outdoor air pollution and other things in the causation of lung cancer. And then, of course, the registry framework was used in evaluating the cervix program, and this finding was fundamental in the state government to launch its own government scheme covering the entire about 31 million women in the state for cervix and breast cancer. And the original plan of the state government to launch only the cervix cancer program was dispelled by us, stating that breast cancers are on the rise, so that it will be unethical to leave a woman unscreened for breast cancer. So now both breast cancer and cervix cancers are into the program. Now that we have an objective index of missing cancer cases, we were able to devise ways to perhaps improve the coverage. One other thing that emerged is the focus that was given to palliative care. Now the government has plans to start cobalt therapy in all the district cancer hospitals so that the state cancer institutions are not clogged with the people requiring palliative care, and there is no need for them to travel long distances to get it. Finally, I acknowledge all the heads, officers, and other staff of the numerous institutes that provided data to this registry. Without their unstinted cooperation and support, this would not have been possible. And then for IARC for the full support. And then registry staff for the diligent work. Thank you.
back to shorter people. Thank you. So our final presenter this morning is Dr. Silvia Francisi, who joins us from the Istituto Superiore di Sanità in Rome. And the title of Dr. Francisi's work is The Economic Impact of Cancer, EPICOST, a population-based study in Italy. Dr. Francisi has a PhD in demography and statistics, a diploma in advanced studies in demography and economics, and first-class honors master's degree in statistical sciences and operational research. So she obviously is going to present a great deal of knowledge here. Please join me in welcoming Dr. Francisi.
So thank you very much. It's a real pleasure to be here, and thanks to the organizer for giving me this opportunity to present the results of the EPICOST study, which is a collaborative multicentric study aimed to evaluate cancer cost of cancer patients in Italy. Italy has a public welfare system which guarantees universal health care to all through the national health system. We did have, in 2017, we had 150 billion euros of total health expenditures, which represented about 9% of the GDP. And out of that, 7% were expenses dedicated to cancer patients. On the other side, we had, in 2010, about 2.6 million prevalent cases, cancer prevalent cases in Italy, and this number is expected to increase up to 3.6 million in 2020, which is the 6% of the population. And these figures are expected to increase both from the side of prevalent cases, because we have an aging population. This is the bad news, so we will have more cases. But the good news is that cancer patients survive longer. There is also an increase in cost due to new target and more expensive treatments. This pose a problem, and there is an increasing concern in the sustainability, the economic sustainability of our healthcare system. And this concern is shared with other European countries, and because we are in Canada, this is a paper published just last year, and the authors underline in this paper, underline the increasing trend of cost directly associated to diagnosis and treatment of cancer patients in Canada. And they also determine that the main cost driver of cost is due to hospitalization. So coming back to EPICOST provides estimates of patterns of care and corresponding health care cost of cancer patients in the areas covered by cancer registration. And in particular, we estimate costs in 8 cancer registries covering about 11 million inhabitants, 1/6 of our national population, for 3 main and most frequent cancer sites: colon, rectum, and breast in the female population. And you will see on the right the geographical distribution of registries. What about the study design? Is a prevalence-based cohort. We estimate yearly cost of all cancer patients alive at a certain date, having had previous cancer diagnosis. We use a phase of care decomposition model. We will see in a moment with we subdivide patients in 3 main phases of care. We linked at individual level each prevalent case of the cancer registry with all available administrative databases, giving us information about direct costs of cancer, of incidence, of diagnostic procedures and treatments. And we reconstruct the cost profile at individual level for 1 year for each phase of the disease, stratified for every variable affecting type of cost, type of service, and cost of treatment. What about the phase of care approach? The rationale is that different periods since diagnosis and different outcomes of the disease determine the phase of the disease the patient is in, and according to the phase, patients have different healthcare needs and different costs. We assume here three main phases of the disease that are defined as follows: an initial phase, which corresponds to the 12 months after diagnosis, where main diagnostic procedures and first course therapy take place; a final phase up to 12 months before death, where mainly palliative care is administered to the patient; and a continuing phase, which is all the time between the two initial and final phase, where the patient is monitored and managed for possible relapses. What about the linkage? Our main source of data is the cancer registry data, which provide us incidence and survival statistics, and identifies the cohort of cancer prevalent cases. And we have many administrative databases: hospital admissions, hospital drug prescriptions, outpatient admissions, and pharmacy drug prescriptions. We associate to each prevalent case all direct costs and events in each administrative database, and we then select just cancer-related events through list of codes that have been detailed by a panel of oncologist experts. I must say that hospital drug prescriptions were available at individual level and were linked in our project, but we didn't choose them in the results I'll show you in a minute because of incompleteness in these data sources and problems of quality of the data included. Here you have the distribution of prevalent case by phase of care that is similar in every cancer site considered. Most patients are in the continuing phase with a percentage varying from 73 to 8%. 15 up to 18% of cases are in the initial phase, and 5 up to 9% are in the final phase of care. If we look at the distribution of cost in percentage by phase of care and by type of service, in blue, hospitalization; in green, outpatient services; in red and yellow, the drugs prescriptions, you see that, and the same for rectum and for colon and rectum, you can see that 55% and 80% of costs for breast and colorectal cancer respectively are due to hospitalization, as was in the Canadian study. For breast cancer, costs of the continuing and initial phase of care are comparable each other, while for colorectal cancers, costs are mainly due to initial treatments. Most costs in the initial and final phase of care are due to hospitalization, while in the continuing phase there is a balance between hospitalization and outpatient services costs. If we look at the individual profile of costs by phase of care for hospitalization, you see that for colon, rectum, and breast female, we have the same U shape with very high costs in the very first months of the initial phase and very high costs in the last 3 months of the final phase. If you look at the same distribution for outpatient services, you see that there is still a bimodal distribution with higher costs in initial and final phases of care, but not in the first months and in the last months of the initial and final phase respectively. This is peculiar to the hospitalization cost. If we look at trends by age of the patients, regardless the type of service and the cancer type, costs are decreasing by age, and in particular, hospital care for patients 80 plus costs about half than for younger patients, and this is expected because very elderly people have comorbidities and they are treated in a less aggressive way and less costly way for cancer. If we look at the cost of the initial phase of care by stage at diagnosis, we see a very remarkable increasing trend, so that early stages cost less because they are treated in a less aggressive way than more advanced stages. This trend is particularly relevant for colon and rectum, but is also visible for breast cancer female. What are the strengths? Is a population-based study, so it provides estimates, real-life estimates. It integrates multiple data sources and allows us to include as much as possible direct cost information from healthcare databases. Is based on individual information, and we use this phase of care approach, which is appealing because it allows us to incorporate all phases of care, the natural history of the disease and corresponding patterns of treatment. And we also use this direct method to select the cancer-related events rather than using the control cohort method, which was more suitable in Italy because it makes results across regions more comparable. We have several limits, some related to the data, which, as I said before, are collected for administrative purposes, therefore are incomplete in some cases and of poor quality in some others. Therefore, hospital drugs were not included. And there are also missing data sources, like for instance, hospices and home care information, which weren't available at individual level, not linkable. We also have a methodological issue that is the continuing phase of care we consider all patients in this phase as homogeneous, but they aren't. It's a mix of patients with different healthcare needs, potentially different healthcare needs. There are patients in chronic conditions, patients cured from the disease, and patients diagnosed with relapses. In conclusion, this type of study, this type of estimates by phase of care and type of health service is an important input for economic evaluation. It justifies screening and intervention programs and provide foundation for policy and planning resources to prevention and control initiatives. The main drivers of cost are hospital admissions, stage and age are the main determinants of cost at the individual level, and in general, EPICOS confirms the importance of primary prevention and early diagnosis also in a public health perspective. I would like to thank you, the working group, which is very multidisciplinary one, includes oncologists, statisticians, epidemiology, and so on. And I would like to thank you for your kind attention.
We're officially out of time, but I think with the wealth of knowledge shared, I'd like to at least try to fit in one or two questions. Is that good, Nan? Yeah? Okay, we can fit in a few questions. So are there any questions? If so, please come to one of the 3 microphones in the room. Really? All right.
Hi. I have one question of the last presentation of the EPICOS. What it wasn't clear for me, it's a software already set up and that eventually it is possible to share it or to tropicalize to other countries, or I didn't understand how you develop the software for doing the analysis. So you could just tell us, and if it is, how we can get it or collaborate in order to get some costs in other countries. Thank you.
Well, okay, thank you for your question. No, we didn't really develop a software. We tried very hardly, but at the moment we have some SAS routines that perform the analysis, the statistical analysis. We received another grant just this year, and we are planning an EPICOS 2, and we are planning to develop also a tool for cancer registries to participate. At the moment, the project is an Italian project, but there is also a pilot included in the last joint action, cancer joint action, in European cancer joint action, and we are planning to collaborate with other European countries. So maybe we can also extend to other registries in other countries. So you are very welcome. But you can contact me for more details, and I can share what tools we have.
Are there any other questions? Yes.
Hello. For the ICD-03 version 2, do you plan any translations, or could you comment a bit on translations?
Yes, so the copyright of ICD-0 remains with the WHO, and as for the previous versions, requests for translations are always sent to the WHO. But then if you, for example, already have a translation and just want to translate the changes document, this is the NAACCR document and can be translated for the use at your registry. It's actually being translated in Japanese now. But for the translation of the whole book, then the copyright stays with the WHO.
I'd like to thank all of our speakers.